So welcome everyone to Let's Code Together for the July session. My name's Jane Knight and I'm an instructor with the MedDRA MSSO, and I'm also joined today by my colleague Dr. Caroline Wilson.
Hello and welcome everyone.
And there we are, we'll give you a wave. So the first slide is just a disclaimer notice, explains that MedDRA came about in the mid-1990s. It's owned by the ICH. It was an ICH initiative, and at the time the MSSO was put in place to maintain and distribute MedDRA. The activities of the MSSO are overseen by a management committee with representatives of both the industry and the regulatory authorities across ICH. This is the copyright notice explaining that MedDRA is owned by ICH, as is the material that you see today. So if you do use the material in any way, you need to acknowledge ICH. And if you change it, you need to explain how you've changed it. But as I mentioned, we don't make these slides available because we feel the value of the session is in the discussion, not in the slides themselves. We want to make it as interactive, so I've already explained we're going to use the questions panel for you to ask questions and make comments. Sometimes we might not all agree on the term that should be selected, and in these instances we have to agree to disagree in the interests of time. We can't take requests to code specific verbatim terms during the session through the questions, but at the end there will be an option for you to propose some new examples, and some of these that you'll see today have come from previous audiences at the sessions. Please though make sure that your examples that you'd like us to consider are of interest to the wider audience, nothing that's too specific to your therapeutic area. I mentioned already that we use a polling application for you to participate in some of the quizzes, and the easiest way for you to join this is to scan the QR code with your mobile phone. That will allow you to join the quiz and respond voting through your mobile phone. The other way of doing it is to use an internet browser, either on the computer or cell phone, and you do this by typing in polev.com, nothing more, at the URL bar at the top, just that, nothing else. When you see the screen on the right, you enter my name, Jane Knight 855, as the username, and you click join. It's completely anonymous. We can't see what your response is. So you don't add your name, you put my name because that will link you to our presentation. The first poll is here for you. Where are you joining us from today? Where are you joining us from today? And I'll just check. I can show you the poll again, this QR code while you're responding. I can do it myself to check it works. Yeah, where are you joining us from today? Oh, there we are. Oh, wide distribution today. It's far away as North America to Australia. Caroline, you're my geography expert.
Philippines, China, Korea, Australia, I see India.
South Africa.
Then we see South Africa, North Africa, US. Oh, it's either very early there or very late. I see Russia, Spain, buenos días, bon dia to Portugal. Italy, buongiorno. France is there.
Wow, such a spread. Thank you all. Well, it seems that the poll is definitely working. It's great. Wherever you are in the world, you're very welcome today. It's lovely to have you with us. So this is the web-based browser demo. If you have your own credentials, you can use your own access to the browser, but in case you don't have access, you can use this one. The username is training, and here's the password. Caroline's going to put the details in the chat for us, so if you need access during the session, you can refer back to the chat section, or you might want to just take a snapshot of it, perhaps with your phone or however you wish to do it, the snapshot in the tool. Okay, we'll move on in the interest of time. So challenges in coding, sometimes there's not always an exact match. Sometimes there's more than one possible approach. And we see that even in the points to consider document. Sometimes we understand a term differently. And what we do when we code is we make the best approximation. That's what Carol Ann and I tend to call it, the best approximation. But overall, we always code as reported without assumptions. And we always have a picture here just to demonstrate how sometimes events are understood differently, just like situations in life and the way you express something. And here we have a cartoon which says, my boss told me to hold the ladder while he's on the roof, and I'm holding it. And we can see that the workman is holding the ladder, but he's doing so inside the diner with a cup of tea in his hand. So this is just to show that those words can be ambiguous. And just like our reported verbatims, they can often be ambiguous. And it's sometimes only when you ask a colleague, what do you think about this term, that they give you their interpretation of the same words. So that's what we mean here. Medical judgment, well, coding is all about applying rules for consistency, but also using medical judgment to manage the risks to patients, and it's that balance. Medical references are helpful for understanding the reports and making the decisions on which term to select, and you'll see that in the session today. Sometimes it's even you can't find a term and it's necessary for you to request a new term to be added to MedDRA to represent the reported concept. So all of these things are what we need to take into consideration before we go near the browser. And having said all that, let's code together. And I'm going to cover the first term, but just before I start, I'm going to switch my camera off because I find it can be distracting for both of us. So our first example is an NSAID, exacerbated respiratory disease. So what's being reported here? Well, we've got non-steroidal anti-inflammatory drugs there, and it's exacerbating respiratory disease. But is this something we need to clarify? Is it clear enough? Do we need to split this somehow to capture the worsening, or is it clear, or is there a combination term? Might this be a known entity in itself? So where would we go with this one? How would you handle the reported event? I've given you some thoughts there that would go through my mind when I first see the term. What is your thinking on it? How would you handle it? Anyone got any thoughts? Hopefully it's working. Split code. Now that's interesting. I wonder how you'd split code that. Reaction, aggravation, and allergy to NSAIDs. Aspirin exacerbated respiratory disease. Now this is interesting. So somebody's found a term which actually looks very similar to what we've had reported, but it's not NSAID, it's aspirin exacerbated. Query for the kind of NSAID, and then maybe code to the aspirin exacerbated. So I think a number of you, looking at the speed with which you've come up with that, I'd say a number of you have done your homework preparation on this before the session. So thank you for that. So you've given us a few options there, a mixture of split coding, looking at an allergy, or looking at the aspirin related terms. So let's go to the browser. I'll start from the website so you see me do it from the beginning. I don't want it in Korean. Let's switch to English. It's got the training password in it. There we are. So let's have a look then. What are we looking at? We're looking at the so let's start with that exacerbated. Let's start with the term that some of you have already mentioned. You've done the homework, so let's exacerbated and aspirin. Let's see what we get. So here's the term that you found, aspirin exacerbated respiratory disease. That looks very similar to what we've had reported. It is there. If I put my cursor on it, I can see on the right hand side it's there. I'll just make this slightly smaller so I can, oh no, other way. I can see where it's placed. It's within the respiratory De Morgan class, and it's there, primary under bronchial disorders. So although it does have a link into the allergic conditions, that's secondary. And I can do a right-hand click and go to browser and have a look at it. So here it is, aspirin exacerbated respiratory disease. Well, aspirin is related to the non-steroidal anti-inflammatories, and there are some analgesic asthma syndrome is an LLT underneath it. Remember that we generally think of these as being synonyms or quasi-synonyms, as there's nothing more specific than that, aspirin exacerbated respiratory disease. So that does seem to be around, although it's not exact, it's close to what we're looking at. Otherwise, we'd be looking at getting too general, wouldn't we? Respiratory disorder. So let's go back to our slides. I won't spend too long on it because there's nothing there. But one thing I wanted to point out to you is that we had a recent change request for this one. Somebody actually asked us to add the term NSAID exacerbated respiratory disease based on a case of ibuprofen-induced respiratory disease, which raised the question of whether there should be a more specific term at the PT level, and then do a swap, and the aspirin term would be demoted to be an LLT under the new PT. So that was the suggestion. It was considered by our team of international medical officers, and it was approved. The proposal was to add a new LLT of NSAID exacerbated respiratory disease, but not as requested, because what happened, have I highlighted it there, that the PT aspirin exacerbated respiratory disease would be demoted and the new PT of NSAID exacerbated respiratory disease would be added. So I think the point I wanted to make here is it's always a good idea, if you've got something that you really feel the concept isn't in MedDRA, have a look at the supplemental terms in the browser, and I can show you how to do that. That you would go to your browser and you would change it. If you have a look here at the top, it gives us the option here. We're looking at the release version. So if I do that, and then I can do the drop down and I can change it to supplemental, and it will then change and go pink. Then if we did the same again, exacerbated respiratory. Let's see if we can find out. You'll see what they look like. I'm sure a lot of you are familiar with this, but here we are. We've got the aspirin exacerbated respiratory disease and the NSAID exacerbated respiratory disease. Both of them have got a green dotted line around them. This is because there's a change that's affected both of them. One of them's been demoted and one of them's been newly added. And if I go to the browser, I can see there that it's down here. There it is. There's the PT, and it's got these terms have all been highlighted as being changed. Although they're not new, a change has affected them. And that change being that they're now moved to a different PT, this newly added PT. So that's what I wanted to show you there. It's just worth being aware of how to do that. Okay, so there we are as a reminder for you. And the learning points from this is that when a concept is not adequately represented by existing LLTs, remember that you can consider submitting a change request. And that's something that's free for you to do, part of your subscription. Check the supplemental changes, and I've just shown you how to do that. These are terms which have been approved for addition, but they're waiting for release in the forthcoming release. And then with the new release of MedDRA, you would up version. So what would we code it to? Well, in the meantime, although it's not perfect, I would select the LLT and PT of aspirin exacerbated respiratory disease. That's only a temporary holding place, and I would up version in September when a more appropriate LLT is available and we see it there. And as I said, a number of you have clearly done your homework on that, so thank you. Any questions on it, Carol Ann, on that one?
No questions so far.
No?
Jane.
Thank you very much. No questions. That's good. So let's move on with our next one. The next one is nebulization device didn't work correctly, and the patient is not sure that he received the intended dose. So what do we have here? Do we have a device issue? Is it a medication error? And was the correct dose administered? Well, I'm not sure any of us can know the answer to that question. Was it administered or not? The patient's not sure. So let me see, I've made it that bit easier for you. Here's a multiple choice of a few terms that we identified that were going through our mind. You can have a vote on these. Do you think it's a device malfunction? You can select as many as you need here. Although it says LLT, you can select as many as you want. Device malfunction. Is it a drug delivery device system malfunction? Is it an incorrect dose administered by device? Partial dose delivery by device, partial dose delivery by product, incorrect dose administered by product. Oh my goodness, they're all so similar, aren't they? Inappropriate dose of drug administered. I'll give you a moment there to vote. Sometimes we get feedback that we don't allow you enough time to vote. And then at other times we're conscious that we want to cover as many examples as possible because very often time runs away with us in these sessions. So let's see how you're doing. How are the votes looking so far? Well, the most popular one so far is drug delivery device system malfunction. Incorrect dose administered by device is also quite popular there. Now this is where you change your mind, isn't it? So let me lock the poll. That's where we'll leave it. That's our most popular choice. So let's browse and see where we go. I'm going to change this back to the regular release version, first of all. And now I'm going to do a top down because I know that there's some kind of product quality issue, the device malfunction of some kind. So I'm going to go to the device issues and I'm going to look down and see what we've got. We've got in product issues, we've got an HLGT of device issues, and then there's a whole HLT of device malfunction. We've got some specific malfunctions, computer issues or electrical issues, but we don't know that. So I'm going to try this device malfunction, not elsewhere classified, see what I get with that. Have a look down. Well, there is a general device malfunction term there. See what comes under that. The device, they've told us the device has malfunctioned, so that's what they have told us. We know that the device was giving a drug, although it's probably not a combination product, I wouldn't have thought. So device malfunction, I think, probably looks like to me of those. A few of you mentioned the drug delivery device malfunction, drug dose omission by device. That one here, no, that one's device malfunction, drug dose omission, drug delivery device malfunction. I can't.
That's just incorrect dose administered by device.
Incorrect dose administered by device is another one there. Incorrect dose administered by device. That one's primary elsewhere. So I can do a right-hand click and I can see where that one is primary. Open details. That one I imagine will be in the medication errors. There it is, because medication errors and other issues. So not having the correct dose is an issue. So that's where I could go, and the incorrect dose, we'd expect to find a term from somewhere in that SOC. So injury poisoning, here we are, medication errors and other product use errors and issues. So remember, it's not just about the errors, product administration errors and issues, here we are. Drug dose omission, drug administered in the wrong device, come down. Incorrect dose administered by device, that's the primary location of the one I was seeing elsewhere. It's multi-axial, with the primary here being the issue that the incorrect dose was administered, and that one. So let's have a look, and I'm just going to type it here because in the drug device, I forget where it goes. Drug device, malfunction. That was the one that some of you suggested. No, how do I, drug delivery system. Drug delivery system malfunction is the one that you suggested, and it's in the product quality. I don't know why in the heat of the presentation of the moment, it's here under product quality issues. Now, this is it. So it's not with the devices. And the reason for this is that this is probably intended to be used for a combination product, because we're talking about the drug delivery system. It's a drug delivery, whereas before I was in the device section. That's why we're now in the more general product quality, not necessarily just the device, because it could be related here. We've got the drug delivery device. That's why I wasn't finding it. So let's go back to our slides and see where does this take us? Well, the next step we think is that we should look at the MedDRA points to consider companion document. And this one gives us some information about the concept of a medication error. It just as a reminder there, it's a preventable, medication error is a preventable event that may cause or lead to inappropriate medication use or harm. And the key thing is, while the medication's in the control of the healthcare professional, patient or consumer. And the point at the bottom that we've highlighted is that some situations, such as product quality or product supply issues, are outside of one's control, not normally classified as medication errors, but they can result in a medication error. And that's what we're seeing here, really, in the incorrect dose is being administered as a result of a device malfunction. And that's the example that they give us in the companion document. Another section there from the companion document is looking at the differences between a device error or wrong technique and device malfunction. And when evaluating medication errors involving devices, it's important to capture the specific device-related event. So this is the malfunction. This is emphasizing that in this example, we do need to split code. We do need to capture the malfunction as well as the incorrect dose being administered. The next thing here, so this is what we've taken from the MedDRA Term selection points to consider. We've taken this because this is what we're all familiar with, saying about when you have a provisional diagnosis, a possible diagnosis, you treat it as if it was confirmed. And it's exactly the same here with the incorrect dose. The patient is not sure that they had the correct dose. So in other words, it's a provisional diagnosis, if you like, of an incorrect dose being administered. That's how we would regard this. And so our learning points are that we would split code and select separate LLTs to capture the device malfunction and the resulting administration error. We don't make an assumption that it might be a low dose if there was a malfunction. It could be a high dose or low dose. But we would, as I say, based on the coding guideline from the points to consider and the companion, we would see this as being a suspected medication error, suspected incorrect dose. So based on all of that, we would select device malfunction and incorrect dose administered by device. And the reason for that is that I'm not sure here the nebulization device is a drug delivery system. I would rather choose a device malfunction. That's my preference on that one, rather than the term that you suggested in the multiple choice. What about you, Caroline? Have you got any comments on that one?
Yes, Beryl has exactly raised the question, but you have answered it already. Do you code incorrect dose as you are not sure if it is the case? The only thing that is definitely known is the device problem, but it's a suspect, so to say, diagnosis, suspect condition, a suspect medication error, and that's why it needs to be captured.
We feel it's better to take the worst case scenario. Yeah. So the next...
And there's one other comment from Laura. So she said, why not use circumstance or information capable of leading to device use error?
Device use error. Well, we don't know that it's a device use error. Capable of leading to medication error is a term potentially, but I think it's quite general, and we don't know that it's a device use error because it's just the device isn't working correctly. That device use error suggests that somebody's using the device wrong. That's different from a malfunction. Caroline, you got any thoughts on it yourself?
No, that's exactly what I would have answered.
These are I know you're the expert on medication errors. That's why I would defer to you for anything too tricky here.
Yeah. I would also go with device malfunction. It could be that this nebulization device is a system, but a delivery system, but we are not sure. So I would rather also prefer to select a more general term. And as Jane already mentioned, it's a suspected medication error due to the device malfunction. Because of the malfunction, you would always consider this an error, an accidental occurrence, and that's why incorrect dose administered would be correct. We don't know whether it's an incomplete dose or too much. It's not explicitly stated in the verbatim. That's why incorrect dose administered by device would be the correct choice here.
Thank you. So I've got a similar one for you next. Nebulization device didn't work correctly. Well, we've already covered that, haven't we? And this time, what is new that we need to capture? The treatment took longer. So what's being reported here? Is it a device malfunction? Well, we've already established that in the previous example, it was a device malfunction. Is it a medication error? Well, we've seen from the companion document that when there is a product quality issue, it can lead to a medication error here, that the treatment took longer. So how can we capture this? Is there a single term, or are we selecting our device malfunction term and now looking for a term for the fact the treatment took longer?
Just to let everybody know, the verbatims are always put in the chat. So if you don't recall exactly the verbatim, you can find them in the chat.
I forgot to say that. Thank you, Caroline. So remember now, the treatment took longer. Somebody's given us something to think about to start us off. Therapeutic product effect delayed. Incorrect drug administration duration. Drug administration duration too long. Drug administration duration too long. This is interesting. This is interesting. Split the term. Device malfunction, thank you. Yeah, we did that before, didn't we? And drug use longer than labeled administration duration. Now someone's come up with something different. Device malfunction and drug administration rate too slow. Did you see that one? Most of you are looking at a term that includes the duration being long. But at least one of you there has found a term that says rate too slow. So we've got two concepts here being proposed. You're going for duration, somebody is saying. Device malfunction, yeah, our device malfunction that we had before, and device effect delayed. Now that's different again, isn't it? So let's move on. Thank you for those. You're really on it today with that. Let's go back to the browser and have a look ourselves and see what we've got. Well, as before, we've got the product issues, the device malfunction. So I think the main thing we want to look at this time is the difference between your proposal for the rate being too slow and the duration being too long. And you had variations around the duration, didn't you? So let's go to the injury poisoning again, medication errors. So let's have a look at the administration errors and issues, because it is at the stage of the administration. So we've got, what have we got here? We've got, let me scroll down, inappropriate schedule, incorrect dose, incorrect drug administration rate. So that was one of them that somebody had suggested this. Drug administration rate is too slow. The treatment took longer. So was the rate too slow? And the PT next to it is the other one you suggested. Drug administration duration was too long. The drug was administered over too long a period. So what's the difference between these two? And then labeled duration is different again. Now this is, when you talk about labeled duration, that is what's in the prescription, what's in the label, the length of the duration of the treatment, not so much that a dose took too long being administered, but that it was beyond the labeled duration. So somebody's taking a drug for longer than they should do, as in the label, for a longer period of time. Now at this point, I'm going to go to the concept descriptions and I'm going to look and see if it helps me with rate. Rate is the amount of drug, so the dose administered per unit of time. So if it took too long, the rate would be a lower amount of drug over a unit of time. And then it can also do the same for D for duration and see if it helps us distinguish. There's the D for duration, and duration is the length of therapy or duration of therapy. Oh, does that help us? Well, I think it comes down to some judgment to some degree here. But our learning points is that we do need to select separate LLTs to capture the device malfunction and the resulting administration error. We would search top down, as you've seen me do, and as some of you had clearly done before coming along to the session, to capture as specific as possible. And which one are we going to go for? Well, based on the concept descriptions, we're going to select the device malfunction from the previous example, and I'm going to select drug administration rate too slow, incorrect drug administration rate, because the treatment is taking longer. It hasn't told us that it's over a longer duration, like something that should be taken for a week and it's being taken for 2 weeks or something like this. It's that the device is not working correctly, so the treatment is being given, but it's being given too slow. It's taking longer, and I would take that as the administration rate is too slow. But we may have some comments on that one, Carol Ann.
No comments so
No?
far.
Ooh.
And I agree with you, Jane, because the dose is correct. The dose is provided by this device, but it took longer. So because it took longer, then the rate is too slow.
It's a single dose, isn't it, Carol Ann? It's a single dose that's being given, but it's being given. So it's not that more doses are being given. If it's a longer period of therapy, you're giving more doses over time. But here we're giving one dose. It's spread out. It's become elongated. So I think on that point, before anyone else can give comments, I'm going to move on and hand over to you, Carol Ann, to do our next session, our next section of terms.
Yep.
Thank
Just
you.
a moment.
Thank you for your comments there. That's good.
Oh,
of course, I might have some challenges on that one. Well
Here
done.
we are.
Thank you. I can see
my screen.
Yep.
Okay. So here the next example is the last one for today, which relates to the respiratory system. It is reported that a patient suffered nocturnal hypoventilation. We will first have to understand the medical condition, whether it is related to a device or whether it's sleep-related, representing a sleep disorder, and whether the fact that the hypoventilation occurred at nighttime has to be captured or whether we have to prioritize the information in this combination term. So how would you approach this verbatim? Which LLT would you select based on these considerations? Hypoventilation, sleep apnea syndrome, sleep apnea hypopnea syndrome, hypopnea syndrome, nocturnal dyspnea, breathing-related sleep disorder, or would you seek clarification from the reporter? What would you do? I give you some time. remember, and Jane has put the verbatim in the chat again. Nocturnal hypoventilation was the verbatim. Now let's see what you're going to. Most of you are voting for hypoventilation, but others also for nocturnal dyspnea. So we have a split of opinions here. Majority is going for hypoventilation and for nocturnal dyspnea. Now let me close the poll. Here we are. And look into Dorland's in order to get some clarity about the medical meaning of these terms. Hypoventilation is a state in which there is a reduced amount of air entering the pulmonary alveoli. So this needs to be distinguished from hypopnea, because this term now relates to abnormal decrease in the depth and rate of breathing. And dyspnea is a much more general, it's much too vague. This term refers to breathlessness or shortness of breath, any kind of difficult or labored respiration. So you can see that hypoventilation and hypopnea have to be clearly distinguished. And this is also what you can then see in the MedDRA browser, because both of them, let me log into the, oh, now we are with Chinese, English, log in. Here we are. So if I enter hypoventilation, into the search window and look for related terms, here we are. Here's the hypoventilation. Right mouse click, go to browser. And here we are, hypoventilation, here it is. And you see above of it, hypopnea. So both are represented by two separate PTs because they are representing separate medical concepts. And they are grouped under the HLT breathing abnormalities. So you will also find the breathing related sleep disorder under this HLT. But you see here, it's a green square around this PT, so it's not in its primary SOC. And if I click on the PT, you'll see in the term details window that it has its primary SOC in psychiatric disorders and secondary linkages to both nervous system disorders and respiratory, thoracic, and mediastinal disorders. So this is a sleep disorder, and no sleep disorder was reported in our case. Now, what about the other terms that we saw in the poll? Sleep apnea. So we have the sleep apnea. It's grouped under sleep apnea syndrome. Again, go to browser. In SOC respiratory. Here we are. And you will see that the sleep apnea syndrome, sleep apnea, hypopnea syndrome, and also hypopnea syndrome, they're all grouped under the same PT, sleep apnea syndrome. Here they are, sleep apnea syndrome, hypopnea syndrome. Here they are. So is this then now a correct code assignment? Would one of these LLTs really adequately represent the reported condition? Let me switch back to my slides. So sleep apnea, according to Dorland's, are related or describe a transient period of cessation of breathing during sleep. Whereas dysomnia and the breathing-related sleep disorder is a part of this concept, so it's a subtype of dysomnias, dysomnias, they represent really sleeping disorders, a group of disorders which includes the breathing-related sleep disorder, one of the LLT options in our poll. Assignment of such a term would not be suitable because no sleep disorder was reported in our case. And sleep apnea would also not be suitable because no cessation of breathing was reported during sleep, nocturnally, during nighttime. So what can we learn from all of this? We should, of course, always try to capture all reported information, the underlying medical condition, the hypoventilation, and the time point of occurrence of this hypoventilation. We learned that the dysomnias are different medical concepts. What was reported represents a respiratory disorder, not a sleeping disorder. We cannot capture the fact that the hypoventilation occurred during nighttime. If further clarification would be relevant for the product in question, then query to get additional information about this breathing disorder. Because reporting is really not always precise, may sometimes omit relevant information. So sometimes it, depending on product-specific considerations, it would be necessary to query to get more information about these circumstances and the background. But if no further information can be obtained, code as reported without making assumptions, without adding information. And that's why we would suggest to code to hypoventilation in this instance, the underlying medical condition that was reported. We would not capture the nocturnal aspect, but we would capture the basic underlying medical condition. But you may also decide to query if this is relevant or these circumstances are relevant to your product. Any questions?
Yes, Caroline, we've had an interesting comment from Ursula. Maybe I think the result of the situation, but her suggestion is, what about the term transient nocturnal oxygen desaturation? It might be interesting to discuss that for our group.
Yeah, that may be a consequence of the hypoventilation, but it's not really reported. It would, we always try to code as reported. And what was reported here is the hypoventilation. From the medical perspective, yes, this could be the consequence, the sequelae of the hypoventilation, but this is not reported in our verbatim.
And the PT for that LLT is hypoxia. So I think that illustrates what you've just said, Caroline. It is the result, isn't it? Low oxygen, hypoxia.
Yeah. Yes. It would be the consequence of hypoventilation. Yeah.
That's the only comment. Oh, nocturnal dyspnea. What about nocturnal dyspnea, May says?
The dyspnea, as mentioned before, when showing the definitions in Dorland's, dyspnea is referring to any kind of a labored, difficult respiration. So it's a much more vague term than hypoventilation. Hypoventilation is really a diagnosis because it's referring to the fact that the diffusion of oxygen in the alveoli is restricted. So that's why capturing the hypoventilation would be really necessary here. Dyspnea would be too vague.
Thank you very much, Caroline. That's everything.
Then I will continue. And we will now discuss some verbatims related to indication coding, a topic that was frequently mentioned by previous participants as a topic of interest. So that's why we are addressing these terms today. And many of those were really proposed by previous attendees. Here's the first one. The indication for product use is reported as prophylaxis of rickets. Do we understand what is being reported and what is being prevented? So which LLT or which LLTs would you select or would you query? Rickets, prophylaxis, prophylaxis against vitamin deficiency, unspecified vitamin D deficiency, vitamin D supplementation, or would you seek clarification from the reporter? What would you do? In the indication was prophylaxis of rickets. Prophylaxis of rickets. Now let us look into the current poll. So most of you are going prophylaxis against vitamin deficiency, some of you for prophylaxis, rickets, others would seek for clarification. Again, quite a split of opinions here. But most of you would go for prophylaxis against vitamin deficiency. Let me close the poll again and look into the Dorlans. So let us first check whether rickets are always caused by vitamin deficiency, namely vitamin D deficiency. So when looking into Dorlans, you can see that it is caused by a variety of defects in vitamin D, calcium, and phosphorus homeostasis, including dietary deficiencies or malabsorption, primary disorders of bone matrix, and acquired or inherited metabolic and hormonal abnormalities. So you cannot really say that rickets are always caused by vitamin D deficiency. So, and this means that coding to a term representing vitamin deficiency or supplementation would not be appropriate here, because we do not know the exact background of this potential ricket disease. With this, we clarified the medical background, but how to approach similar verbatims when coding indications? If you are not very familiar with indication coding, you should first check the guidance in the MedDRA Term Selection Points to Consider document, where you'll find a separate chapter for indication coding. Here you see it. We are first told that indications can be reported as medical conditions, prophylaxis of conditions, replacement therapies, procedures like, for instance, anesthesia induction, and verbatim terms like, for instance, anti-hypertension. And that regulators may have different specific requirements for indication coding. Therefore, it is important that you familiarize yourself with the applicable regulatory requirements in your country. And that is why we cannot make generally valid statements here. The basic rules for indication coding apply, but more specific local regulatory requirements may have to be followed in addition. So you see some examples here. If it's reported, hypertension is reported, or antihypertensive, you would code to hypertension. If a chemotherapy for breast cancer is reported, you would code to breast cancer. This would be the indication for use. When coding verbatims which describe the prevention of diseases, we are told to search for a combination term in MedDRA to capture both the prevention plus the condition to be prevented. So sometimes you find these terms in MedDRA. For instance, prophylaxis of arrhythmia can be coded to arrhythmia prophylaxis, or prevention of migraine can be coded to migraine prophylaxis. But if no combination term can be found, the preferred option provided in the ICH guidance is to code to prophylaxis or prevention plus an LRT for the condition, so to split code. But as an alternative, you also have the option to only select either LRT prophylaxis or prevention alone, or only an LRT for the condition. So you have two options here. Either you split code, this is the preferred option, or you code to either prophylaxis alone or to the condition alone. As always, the approach selected should be documented in the coding conventions and applied consistently. Now let me again switch to my browser. And when searching for rickets and prophylaxis, there's no hit. So I can now exchange prophylaxis by a synonym, prevention, but again, nothing. There's no combination term. So we would need to, taking the preferred approach, we would need to split code. And here we have the rickets grouped under PT rickets. And of course, you will also find a term for prophylaxis. The general term, here it is, and it's grouped, as you can see here, in surgical and medical procedures. Rickets is the condition, and here we have the therapy, the treatment, prophylaxis. One option was the prophylaxis against, and I will just enter vitamin here. We have the prophylaxis against vitamin deficiency, but as we saw in the Darlings, it would not be appropriate to assume that the rickets are really caused by potential vitamin deficiency. It could have congenital reasons, so we don't know. We do not have the information to assume that the rickets, the prophylaxis of the rickets is based on the assumption that vitamin deficiency may occur. Same is true for the unspecified vitamin D deficiency, and the vitamin supplementation, of course, at least would represent a therapy. Here we have the vitamin supplementation. If I click on it, you see it's grouped in surgical and medical procedures, whereas all the deficiency terms, of course, are conditions. And what is reported here is a therapy, not a condition in the patient. So all the deficiency terms would not be correct, would be an assumption. And one other option in the poll was to seek clarification. In my view, this would not be necessary because we can fully capture the reported information by split coding and assigning prophylaxis and rickets. And this is the preferred option, as I've shown you earlier in the PTC document. So if not familiar with the guidance in the PTC document for coding of indications, look into the document in order to better understand how to approach these verbatims. Always distinguish between prophylaxis and treatment of a reported condition and code accordingly. And when coding a more complex verbatim, search for MedDRA combination terms, which would cover the full information. But if no combination term can be found, consider split coding, following the preferred approach of the PTC guidance. So our final suggestion would be to split code by selecting prophylaxis and LLT rickets. But you could, of course, also take the alternative approaches provided in the PTC guidance and code either to LLT prophylaxis alone or LLT rickets alone. So any questions, Jane?
Yes, this one's prompted a lot of comments, Caroline. So firstly, we've had a few comments around if you know the drug. So if you knew the drug, might you code differently? For example, if you knew your drug was vitamin D, could you then code it to vitamin D deficiency prevention? But that's not how it's been reported, has it? It's been reported as prevention of rickets, not prevention of vitamin D deficiency.
Yeah, it's prophylaxis of rickets. So I would still code it as reported. Yeah, based on you could of course have data entry conventions for coding of indications for specific product as in this case where you know that it's really vitamin D, then you may have the data entry convention to always enter the indication as vitamin D supplementation, for instance. But if you are coding out of context without knowing the drug, without knowing any details of the drug, then it would be completely sufficient to say, well, I split code and assign LLT prophylaxis and LLT rickets, because this is what has been reported.
I think comes back to that. So it's that balance, isn't it, between knowing more about the product. If you know, in the example also, it was referring back to the previous example, if you knew with the nebulization device that it was a drug device combination, perhaps you'd select differently. And then there was a bit of discussion around, can you assume that if something is vitamin D, that it's being used for vitamin D deficiency? And my feeling is not, because you might have vitamin D supplementation to boost your levels, not because they're necessarily low. And as you've just said, Carol-Anne, so
exactly what is reported is a prophylactic procedure, and it's not that you can assume already a condition in the patient. So you should really capture the prophylactic aspect. So if you know it's a vitamin D, that your drug is a vitamin D, then you would try to capture the prophylactic aspect by assigning vitamin D supplementation, for instance, or something like that. But as I said, in my view, the split coding to prophylaxis and rickets would be fully sufficient here.
And then Martin's made some comments around distinguishing really between what's reported. Is it the way people are using the drug, or is it the labelled indication? And that's true, isn't it? The labelled indication is more likely to be based on the pharmacological mechanism rather than the therapeutic use, which might be what's being reported by the healthcare provider in these situations.
Yes. Yeah. But you know, even if it's a vitamin D, if your drug is used for vitamin D deficiency prophylaxis, then the prophylaxis of rickets would still be a correct code assignment. It would not be off-label use because it's connected. It's in the same medical context.
So I think that rounds that one up, Carol-Anne. I think we should move on to your next one now.
Okay.
Oh, yes.
Next one. The next reported indication is deworming, and it was suggested by one of our previous attendees. So do we understand what the drug is used for? And is it used for treatment, or is it used for prevention? Can we capture the type of worm, and do we know the affected body site here? So which LLT would you select? So the options are LLT worms, parasitic infection prophylaxis, anti-infective therapy, helminthic infection, or would you seek clarification from the reporter? What would you do? So the indication is deworming. So let us check what you are looking for, going for. Here, the majority is going for the worms, others for parasitic infection prophylaxis, but also anti-infective therapy is chosen by quite a number of you, helminthic infection, and others would seek clarification from reporter. So let us close it and see what we can do here. And I will switch to my browser again. So if I enter worms here, exactly, so deworming, I could try, but quite improbable that I will find anything here. Nothing. So that's why I will go with the worm. Contains search results. We have different worms, but also very general one at the end here, worms. And if I click on it again and go to the browser, you see that worms, here it is of course under infections. Worms, here it is. It's grouped under helminthic infections, and so this seems to be a correct code assignment. And you see that it also has a secondary linkage to gastrointestinal disorders as a primary site of infection by these worms. So under this HLGT, helminthic disorders, you see that there are, besides the HLT, helminthic infections NEC, so where it's not clear, where the type of worm is not clear, or whether when there is a very specific location of the infection, you see that there are 3 specific HLTs for different classes of helminthic organisms, the worms, and these are the cestode infections, the nematode infections, and the trematode infections. What else did we have in our poll? We have the parasitic infection prophylaxis. So this would assume that we have a prophylaxis, so that the patient is not actually suffering a worm infection, but that the drug is given for prophylaxis of such an infection. It's of course also grouped in surgical and medical procedures. And we have the anti-infective therapy. Assuming that the patient is really suffering an infection that needs to be treated. Here we are again in surgical and medical procedures. So what we can do with this? Many options. So first of all, helminth is of course a parasitic worm. So we are the grouping in MedDRA is correct. Also based on Dorland's definitions. Then you see here the definitions of the different classes of worms, cestodes, trematodes, nematodes, which are represented in the 3 HLTs we saw before in the browser. The first 2 represent flatworms, and the last one, roundworms. The cestodes or tapeworms are acquired by accidental ingestion, and all cestodes cycle through 3 stages: eggs, larvae, and adults. And adult cestodes can be found in the intestinal tract, but the larvae enter the circulation and further develop in extraintestinal sites as well, most importantly in the brain, but also in the liver, lungs, eyes, muscles, and subcutaneous tissues. Meaning that a cestode infection does not only affect the intestinal tract. Same holds true for the trematodes or flukes. They may also infect blood vessels, the GI tract, the lungs, and the liver. And as you can see on the last slide, also the nematodes can infect multiple body sites like the pleura, pericardium, peritoneum, skin and subcutaneous tissue, etc., etc. So here are the learning points. Do not make assumptions about the type of worm when receiving such a vague report. We have a very general, vague term in MedDRA worms, and it's grouped under helminthic infection. So that's the best LLT we can assign. Also, do not assume an intestinal tract infection. So the primary infection is always the intestinal tract, but this can further develop in the organism and then really affect other body sites as well. You saw that in the previous slides, that multiple body sites may be affected by these helminthic infections. And if more specific information is needed based on your product portfolio, you may want to query for the type of drug. And many of you voted for that. You would like to have to know the type of drug, the affected body site, and the type of worm. This would then really depend on your internal data entry conventions and internal data analysis requirements. Depends on your product portfolio. Our final proposal is to code to LLT worms under PT helminthic infection, but as mentioned before, you may also query based on product-specific requirements. Did we receive questions for this one, Jane?
No, very little here. Just the only comment Martin just pointed out that here we do have existing worms. It's not prophylactic. The point that we've been making that you need to be clear, is it an existing problem or prevention?
Yeah. So here we are really talking about therapy and not about prophylaxis. Deworming means to get rid of worms. So the worms are really in the patient. Yeah.
Thank you. No, nothing else.
Okay, then I give it back to you, Jane.
Thank you very much. Well, I'm just looking at the time here. I'm going to try and see if I can cover my block of 3 here. So my first one is indication, again, sunscreen for acne-prone skin. So what's this indication? Is it a treatment for acne? Well, it's telling us the skin is acne-prone, but it's sunscreen. So is it prevention of sun damage? Which elements would we capture here in our coding? And what's the most appropriate LLT? What do you think? You can use your browser. Some of you may have done some searching prior to the session. We send while you're just replying to this, we send the terms out 1 week or just under 1 week ahead. So if you sign up later for the session, then you might not get them. But if you can always email us, if you do sign up late and you know that you've missed the week ahead, you can always email us and we'll send you them. So here people are going to code acne, Carol-Anne. Somebody pointed out prophylaxis of solar radiation. Again, prophylaxis against solar radiation. So we're having here a split, probably selecting 2 terms, the acne for the acne-prone skin. But what's the drug actually being used for? Is it the prophylaxis? So let's go. I'm going to move on to my next slide. While we're browsing here, we can browse. And I'd start with, I was looking up your transient sunscreen here. Let's have a look at sunscreen, because that's what we've got reported. And we always start, if we can. No, the only term that includes the word sunscreen is sunscreen sensitivity. That's completely different. I know mine's it's an indication. So it may well be that I can limit it to the procedures SOC, because I know that that's where my terms. Let's put that in there, and let's have a look now for sun on its own and see if there's anything related to prevention of sun damage. Or no, I've limited to the procedures where I know the prophylaxis will be. So I'm going to search for solar, and some of you had done this previously, I know, because you found that term, prophylaxis against solar radiation. Well, I agree with you all that that's a term I like the look of for the sunscreen itself. That captures the sunscreen. There it is. It's a therapeutic procedure. I can do a right-hand click, check that there's nothing else alongside it. But that's the PT. There it is with other prophylactic procedures, not elsewhere classified. Well, that to me captures the sunscreen. Acne is acne. We can look for it, but acne will be acne. So we know that that's in MedDRA as acne. Acne-prone skin. But are we treating acne? Not really, are we? So let's have a look. I can search. Is there something to capture skin that has a risk of acne? MedDRA doesn't have many specific terms, risk of or predisposition to disease. Here are 50 terms, and I've looked through them prior to coming along, and I can confirm that there's nothing there that's prevention of acne or the acne prone, the risk of acne. So because we're not actually preventing acne and we're not treating acne. So my learning points on that is to capture what the product is being used for. And this was the prophylaxis against solar radiation. Don't infer that it's treatment for another condition just because the skin is acne prone, but yet they must have had acne in the past because they wouldn't be acne prone if we didn't know they had a history of acne. So you would, in this case, follow your local regulatory guidance on the coding of indications as your requirements may differ. And in some situations, you may here need to capture the acne. And this is based on the ISO IDMP standards within the EU or even globally. So our final suggestion here is the LLT-PT prophylaxis against solar radiation, but we have put a note on the slide that additional selection of LLT acne may be necessary for medical history and or the indication coding based on the local regulatory requirements. Any comments on that one, Carol-Ann?
Yeah, some of our attendees would like to code this to acne, but you have explained that this is a concomitant disease or medical history condition. So that's why you would expand the indication of this product if you would consider the acne as the indication for use. So that's not the case.
Okay, thank you. So
Martin is saying, what about prophylaxis and photodermatosis? But this is also, photodermatosis is not reported here.
No, that sounds like more of a specific skin condition. What is photodermatosis? It is, they're more like something specific.
Yep.
It might just be sunburn rather than preventing a pathological condition.
Yeah, it's a prophylaxis.
So I'm going to move on to my next one, if unless you've got anything new on that one.
No.
So our next indication is production of cycloplegia and mydriasis. Production of, so this is a bit different, isn't it? What's being reported here? Production of, it sounds like we're trying to bring about a certain clinical state of cycloplegia, and we'll look at what these are, and mydriasis. So is this related to an investigation perhaps, or treatment, some kind of preparation for a subsequent procedure? Do we need to split it to capture the cycloplegia and the mydriasis, or what's the most appropriate LLT or even LLTs? Those are our initial to get you thinking. What would you select on this one? So I've given you some options: mydriasis as a condition, cycloplegia as a condition. Remember, it's an indication. And Carol-Ann's put the term in the chat if you forget what it is. Is it dilated pupils, constricted pupils, a pupillary disorder? Perhaps for both of them, pupil dilation procedure or an ophthalmological examination? Right, so let's see how your votes are going. Interesting, Carol-Ann, look at this one. So the majority by a long way is people are coding for mydriasis and cycloplegia. So the indication to produce something, is this the condition itself? So finally there, we've split between the two. So let's browse. Oh, So where am I? I'm going to look them up. Let's have a look at them up, because we haven't got a Dorland's reference on these because we don't need them based on their placement in MedDRA. So let's have a look. Cycloplegia, the PT cycloplegia. There it is. If I go to the browser, we'll see what it means. I can see what it means by its brother and sister LLTs. It's paralysis of the pupillary maxillary muscle. So it's paralysis. It's making it static. So the mydriasis, it is. Let's have a look at that one. Mydriasis again is the LLT and PT. Right-hand click, go to the browser, and we'll see from the, it's a pupil disorder, so it's related to the pupil again. This one is dilated. So to produce this condition is to dilate the pupils. So the action of the drug is to dilate the pupils, mydriasis, to bring about mydriasis. So once the pupils are dilated, to freeze them there, to paralyze them so that they stick in that position, potentially for some kind of examination to view the back of the eye or an ophthalmological examination. Pupils dilated. So now we have dilatation pupillary and dilated pupils. So what's the difference between these two? So I'm going to have a look at pupil dilation and see the difference. So we've got two of them there. And then by looking up, I found another term, pupil dilation procedure. So we've got the two terms in the list that I've just shown you under mydriasis, and then we've got this pupil dilation procedure. So there is a term in MedDRA to capture the action of dilating pupils, as well as to capture the two terms here, which reflect the fact the pupils are dilated. Here, we're bringing about that situation. That's not what we're treating. We're trying to bring it about. So different from the prophylaxis again. So let's go back to our slides. We've got the introductory guide to show you this time, different from the MedDRA points to consider. The introductory guide gives us some conventions and rules around the placement of terms in MedDRA. And one of the things I wanted to show you was around in section 5 around naming conventions. There's an entry for dilation and dilatation. And how it says here that although dilation and dilatation often are used synonymously within medical practice, for the purposes of distinction in MedDRA, the term dilation is considered a procedure and the term dilatation is considered a disorder. So this is why the word procedure is normally added when in MedDRA, when using the word dilation, to emphasize that it is a procedure and to make that distinction. So based on that, we're going to differ in our view from what you did in the multiple choice. And we would firstly be clear whether the product is to treat a reported clinical sign or symptom or produce a desired effect. And we would not assume that there's an underlying condition. So what I mean here is I wouldn't assume that the pupils were constricted just by virtue of the fact that we are trying to dilate them. It may be that they're being dilated in order to look at the back of the eye, most likely. And our final suggestion here, as production of the condition rather than treating the condition of dilated pupils or frozen paralyzed pupils, is we would code it to pupil dilation procedure. And based on that voting, I'm not sure I want to ask for comments. Caroline, what comments have we got? What thoughts from the group following our walkthrough of our thoughts?
Yeah, Martin is saying this is exactly what is produced by belladonna, for instance. So it's really something that the drug is producing, so for a specific purpose, for investigation. It's not that the patient is really suffering cycloplegia and mydriasis.
And it can be confusing, can't it, with indications? Yeah. And there's an example.
Yeah, you really have to always look very carefully at the verbatims in order to really understand what the drug is used for.
Thank you. So I'm going to do my next one, Carol-Anne, because we were trying to do 10 this session. So let's see if we can get closer to that. The next one is behaviour disorders in autism or Alzheimer's disease. And it's an indication. Now this makes a difference. Behaviour disorders in autism or Alzheimer's disease. What's being treated here? Is it the behaviour disorders being treated, or are we treating autism or Alzheimer's? Well, they're both so different. Is it a treatment for an autistic spectrum disorder or Alzheimer's disease, or is it going to treat both? Well, that's maybe unlikely, but is it treating the behavioural problem? Does it need to be split? And what's the most appropriate LLT? So this is a bit similar to the sunscreen and the acne-prone skin, really, isn't it? You've got a presenting symptom of behavioural disorders, but here it's not being prone to something, they've actually got an underlying condition. So what would you code here? Behaviour disorder due to a general medical condition. Behavioural, two of you have got that one. Behavioural disorder, also autism and also Alzheimer's disease. Sedative therapy. Oh. That's looking for a type of therapy there. Behavior disorder due to a general medical condition again. So I'm going to go, and another vote for splitting. Thank you for typing all of that in. Behavior disorders, now a few people are coding the presenting symptom. Right, wow, let's go and see. I was going to the browser. I'm too soon, aren't I? There we are. Let's go. Firstly, let's have a look at our guidance in the term selection points to consider for these type of indications. And there's some very clear guidance on this. It's in a section under complex indications. And the examples here is that you can have treatment of aggression in autism or treatment of chronic iron overload in thalassemia major, for example. And the third example is prevention of atherothrombotic events in patients with myocardial infarction. So in all these situations, the comment there is that the product doesn't treat the underlying autism, thalassemia or myocardial infarction, but they address the associated signs and symptoms, in our case, behavioural disorder. So it may be necessary to select the underlying LLT condition based on your regional regulatory requirements, but the overall advice within the PTC is that the indication is the presenting signs or symptoms. So we can see that. I don't think we need to browse. I think we'll move on because it's fairly clear, isn't it? We'll be looking for behavioural disorder, behaviour disorder. We know we can find that. So I'm not going to browse, but the learning points are that we would be clear on what the product is being used to treat, capture only the symptom, but do follow your local regulatory guidance. We can't give you advice for every country. It depends on the purpose for which you're coding. It may be that you're following IDMP standards for capturing the drug, or it may be based on separate regulatory requirements regionally. But we would code behaviour disorder, and we would only capture the reported concomitant diseases for the medical history, and also potentially based on your local regulatory requirements if it's needed for indication coding. Any comments on that one, Carol-Anne? No? Well, would you like to try and fit in?
I was on mute. I was on mute because I was typing before. So Martin is confirming this. So IDMP is the IDMP standards really asked for clear differentiation between the indication for use and concurrent diseases. And this drug is not used treating the autism or Alzheimer's disease, but the behavior disorders when the patient is already suffering autism or Alzheimer's disease. So that's why.
And they're so different, aren't they? So we've got about 5
Again, you would expand the indication of your drug, and this would, of course, not be accepted by regulators.
No. So shall I hand over to you, Carol-Ann, for one of your next set?
I think we have 5 minutes. Shall I
try?
Yes, we
try.
We try.
Would you like to try? I know sometimes we've had comments about how we do send out more examples than we manage to get through. And it's not that we haven't prepared, it's just we like to allow plenty time to go with the questions and the comments that you've made. So we do try. I'll hand over.
So here we have the 10th example for today. The indication here is control of blood pressure during surgery. So what is being reported? Is this information clear? Is it describing a therapeutic or prophylactic intervention? And do we know whether the product intends to control high or low blood pressure or blood pressure fluctuation? And can we capture the surgical context with the MedDRA term? So what would you do? Control of blood pressure during surgery. Would you go to intraoperative care, intraoperative complications, intraoperative hypotension, intraoperative hypertension? Would you go to blood pressure management, blood pressure fluctuation, blood pressure inadequately controlled, or would you seek clarification from the reporter? What would you do? So most of you are going for blood pressure management, and some of you may also want to split code here and code intraoperative care in addition. But some of you also would seek clarification from the reporter. So blood pressure management seemed to be the favorite assignment here in this instance, plus intraoperative care. Okay, let me close this and show you shortly in the browser. Intraoperative care, of course, is very vague. It resides in surgical and medical procedure. Intraoperative, me and my typos. You have a typo, you don't find anything. Here we are. It's of course grouped in surgical and medical procedures, whereas intraoperative complications is grouped in the INRI SOC because it's representing a complication in the patient. Here we have it in injury, poisoning, and procedural complications, but this was not reported. There was no complication in the patient. Intraoperative hypotension, intraoperative hypertension, and blood pressure fluctuation would not be appropriate. I won't show them. They are of course available in MedDRA, represent blood pressure abnormalities in the patient, so conditions in the patient. But we don't know the exact blood pressure problem that is to be managed by the drug. And blood pressure management is more suitable. Most of you voted for this one. It's also grouped in SOC surgical. It's the management of the blood pressure. It does not assume high or low or fluctuating blood pressure, but there's no similar term which would capture the surgical context. So if we go for pressure management, you will see that there is no term that would capture here. That's the only one that we have. There's nothing that would capture the surgical context. Blood pressure inadequately controlled was the other option. Again, this would be an assumption. We don't know whether the blood pressure of the patient was previously inadequately controlled. It may well be that the blood pressure problems are only to be expected because of the type of surgery, for instance. So the patient may not even suffer from hypertension whatsoever. So with this, the coding option that we have with LLT blood pressure management is okay, but quite vague and does not capture the surgical context. So best would be to query to find out the product name and what it is being used for. We should not assume anything related to the blood pressure abnormalities of this patient. We would also always try to capture the surgical context of the administration, but we didn't find a suitable combination term in this instance. So we would suggest to seek clarification at the, when looking at this verbatim in order to find out the drug and its therapeutic effect, to be more specific when coding this indication. But if no additional information can be obtained, we would select LLT and PT blood pressure management. The vague term, but it captures the general therapeutic intention of the drug. And depending on your coding conventions, and some of you have suggested to do so, you may also decide to split code and select LLT intraoperative care in addition in order to capture the surgical context. But this is not required by the points to consider document. It would depend on your in-house coding conventions. Any related questions, Jane?
No, there's no related. It might be a device as the only comment. It might be a device to measure the blood pressure. So it might be a monitoring. So
Yeah.
the management, we wouldn't assume blood pressure fluctuation.
Yeah.
That's good. Thank you, Carol Ann. Thank you. Would you like me to take it back for the last slide?
Yes, please.
There's no other comments on that one. So I'll just wrap up. Thank you. Sorry, we're just a couple of minutes over, but we have covered 10 today, so that's better. Sorry if it was a little bit rushed. The session will be recorded, and just as a reminder, if you are new to these sessions, we have a whole long repository of them. We've been giving these sessions now for not far off 2 years, so they're all stored on our YouTube channel, so you can look back. And if you have a look at our website, there's an index document that you can access on the website, which shows you which terms were covered in which session. And when you actually choose a session in YouTube, if you click on the session, it will give you the verbatims in the description for that session. So if you're interested in a particular type of term or therapeutic area, you can do a search on the website so that you know which sessions to look at. The last slide, if you've got a moment to stay, some of you have already found it. We have a poll, an instant poll. This is where you can give us ideas. Tell us what you thought of the session. We can't keep everyone happy. Some people ask us to make it quicker, make more examples. Some people ask us to go slower. So we can't keep everybody happy, but we do our best. And if you give us some concrete feedback, we try, if we can, to try and make the changes. This is also your opportunity to give us some ideas of some areas that you'd like us to address in future sessions. So there might be individual verbatim terms that you've struggled with that you want us to consider for a future session, or some good examples. There might be examples that you use for training in your organization. So give us your thoughts there. And our next session will be in September. So we will come back with the 4 examples that we didn't cover today and some others. So give us your examples here. Everybody we've got some feedback already coming in saying, wishing you all a very nice holiday. So thank you, Mariama. Thank you. You too. I hope everyone does have a very good summer in the meantime, and we will see you in September. So thank you for your participation today. Thank you for your attention, for your interesting comments and suggestions. Carol Ann, thank you for your collaboration as always. Always great fun.
Yes, thank you, Jane. To you as well.
So stay safe, everyone, and your certificate will be available in 2 days. Bye for now.
Thank you, everyone. Bye-bye. Hope to see you in September. Bye.